Hello, I'd like to welcome everyone to the final installment of the 7-week PartSource HTM Leadership Series. Today's session, Using Care Plans to Improve Patient Flow and Capacity, will be presented by Doug Kirsop and is hosted by Guy Mansueto. Before we begin, I'd like to review a few housekeeping items. First, you have a Zoom control panel on your screen. It may be located at the top, bottom, or side of your computer screen. You can minimize and expand this control panel. Second, you can submit your questions using the question portion of this control panel. We will answer questions at the end of the presentation. If your question is not answered, we will respond to you individually after the event. Last, all registrants will receive a link to the recording of this webinar after, and this information will be sent to the email address with which you registered for the webinar. And now please welcome our host, Guy Mansueto. Guy Mansueto joined PartSource in October 17 as Senior Vice President and Chief Marketing Officer. With 25 years in the healthcare industry, Mr. Mansueto brings expertise in healthcare technology solutions for provider, payer, and employer markets. In this capacity, Guy leads efforts to help accelerate growth and facilitates development of medical device supply chain solutions and service models designed to increase innovation around utilization and uptime. Now I'll hand it over to you, Guy.
Great, thank you, Colleen, and thank you to all those who are joining us today. At PartSource, we really believe in the concept of shared learnings and best practices. And the way we do that is through webinars and education such as this. So thank you so much for attending. Our job is really to help further the community of clinical engineering, HCM community in a positive way. So I'm really excited about today's session and our presenter for using care pathways to help improve patient flow and capacity, presented by Doug Kirsop, Transformational Director at Ohio Health. Prior to his current role, Doug most recently ran a cyber cross-functional task force with a 1-year mission to improve the organization's cybersecurity posture. And his work included implementing IoT, vulnerability scanning, and setting up a whole program to automate the whole device management and security for Ohio Health. So really pleased to have him. In the past year, he has been collaborating cross-functionally with the IT leadership as well as the clinical leadership to help evaluate care pathways and the impact on medical devices, medical equipment. This cross-functional team focused on improving patient flow, improving effective capacity, and I can't think of a better person to help introduce this topic to this audience. So I want to welcome Doug, and it's my pleasure to go ahead and pass this over to you, Doug, to continue today's presentation.
Thank you, Guy. Appreciate it, the introduction and the opportunity to be here. Thank you all for joining us today. So, go with the flow. That's a term we've all heard more than once. And that's what we're going to talk about today for some topics that unfortunately are all too timely right now. So we'll jump into our broader education session here and focus a lot on how we can support this and how it impacts us within the HTM community. So capacity management. When we're talking about primarily here hospitals, so inpatient, but hospital capacity management, the term that most places and most literature use are length of stay. That's the patient's length of stay. You'll also see other measures, and we'll talk about some as we spend some time looking at this together. But the most common and fundamental unit is that length of stay. And that is really the throughput or the turnaround time. We look at turnaround time for equipment on everything from repair, doing it ourselves or sending it out. What's the whole process take from start to finish? It's the same thing for a patient. And when your systems that you all work with talk about throughput from a patient point of view, how quickly can we move patients through with the best clinical outcome? It's well established that the shorter the patient's stay in general, the healthier they will be. They are going to acquire fewer hospital-acquired infections. There are less chances for problems. We all heal better in our own environments. And throughput, that's what it's often all about. A big part of that is discharge planning. That is a huge focus for our clinical colleagues these days, in being able to move patients along. There's a lot of talk and focus around that area. It also comes down to, especially in these days, staff and resource planning. And we're going to spend a lot of the second half of our time together here looking at that staff and resource planning. So when we talk about throughput, if we look at it from a flow or a simplified linear, more or less, process map, we're looking at coming in either via emergency care of some type, or by a transfer, or by a recommendation from a primary care or other physician. And then really focused on the whole inpatient care process here. You can see, and I know this is a bit of a squinter, but as we go through the entire process, the size of those bubbles indicate the opportunities and the possibilities for improving patient flow through a system. And it's those areas that we are going to talk about and how we can engage and support those. So this is really throughput, making this flow happen for the patients at the facilities we support. So, okay, so why does this matter? Well, if patients are in too long, and we just touched on a few of these things, but let's expand it a little more. Talking about patient satisfaction, whether your system calls it patient satisfaction, patient experience, customer satisfaction, all of those are used. They all come down to the same thing. And again, poor clinical outcomes. If we can move people through having addressed their key medical needs, their outcomes are going to be better. Of course, the longer they're in, the higher the costs. And the longer that patients are in, the larger a percentage of the cost our facilities bear, which means less money for us. But it is a very real issue, and we'll come back and expand on that a little bit as well. And the one that's really tough right now, crowded hospitals. We had no idea when I was chatting with Guy and others at PartSource how incredibly timely this whole topic would be. As we look at this third and worst surge of COVID, I know that all of your sites are focused on this right now. So I hope that we can get some additional ideas today on how we can better support patient flow for moving patients through and making room, quite honestly, making room for patients who need those beds. So what are some ways that our systems are working on this, and how can we be engaged? Well, the first one is really getting information together and communicating around bed huddles. I will suggest that for, well, let me take a step back. Many of you have people assigned to look after given floors or given areas. If you don't already, this might be a time to think about that, to develop relationships, and not to show up every day necessarily, but at least a time or two a week, show up, put your face in at those bed huddles, or do it remotely, at least be on the phone. Understand what the needs are, what those units are facing, what kind of challenges they expect to be coming, and how can we help that? How can we support that? How can we get ahead of that? You know, are they going to need more of their standard equipment? Are they being asked to do different kinds of tests? Are they anticipating that they might have to change their level of care on that floor? Those are all areas where we would be intimately involved. So be sure you stay up with what's going on your floors, not just at a whole site level, but on the individual floors. And likewise, in rounding, you know, toward the end of when rounding is done each day, check with the charge nurse. You know, anything come up, you know, if there's something that we can do to help. That is at a minimum relationship building, and sometimes there will be things. Often they'll say no, but thanks for checking. And in these days, when they say that, know that they really mean it. Many of our sites and systems are looking at staffing and what are the roles, how do we help keep people working at the top of their license, right? That's a term we're all hearing, so that we make the best use of the entire staff, free up people for areas where they're really needed. How do we make sure that we are supporting that as well? Sometimes that means the specialized equipment, whether for COVID patients or otherwise. A lot of the work in inpatient flow is coordination and communication. You all see it when you're out, you know, on floors, that one functional group doesn't necessarily always talk with another one. The planning and information isn't shared. So there's a lot of that kind of work that's going on. Often that one of the end results of that is information being shared via new reports or dashboards. Some of those are very useful. You know, use your contacts, you know, leadership, reporting, analytics teams, others that you know, find out what's there, and start to look at the ones that make sense to you. We're certainly not going to need all of them, but there are some that will really help, the ones especially that are more operationally focused. And then a big area is centralized coordination. We're going to hit on that a lot here again in the second half. But more and more there is a move to centralized patient flow, especially when you have multiple sites, so that your system is making the best use of each bed. A lot of organizations talk about right patient, right bed, right place. How do we help make sure that happens? And we'll come back to this several times, but bed, the word bed, is really a rolled up catch-all term. That is, yes, the physical bed, but that also means everything that goes with it to be able to support a patient. And most of what goes with it on the physical side of things is what we support. It does also mean staffing. It means a bedside nurse, which is the biggest gap that most of our organizations have today. But it's also all of the equipment to go with that, quote, bed. So how is this patient flow measured? So we talked about length of stay a little while ago. Most of our systems are required to use and to look at what's called the geometric mean length of stay. So geometric mean, so it's the mean average, and by using the geometric mean, it gets rid of the outliers. So the sort of the mistakes of the people who really shouldn't have been there in the first place. Data errors and mistakes for entry, not the people aren't mistakes, but there are mistakes in data entry for the system, or people who really were just there for an extremely short time. And also, you all know that in your system, there are long stay patients who are there for a variety of reasons. So basically, we're taking those out of the calculation. And overall, then what is that mean length of stay for your patients? There is a big table, updated frequently, that ties the patient's DRG, so their working diagnosis, their primary reason for being there, as well as the other complicating factors, significant complicating factors, in a table that associates those with the length of stay. Our friends at CMS assign that. They're the ones who keep that. And that is the key for how insurance reimbursements are determined. Excuse me. I made a reference earlier to our sites having to pick up a larger portion of cost when patients are there longer. Once a patient hits their geometric mean length of stay for their DRG, insurance reimbursement goes down significantly. And hospitals are limited by how much they can charge their patients for the rest of that time. They can continue to charge them, but it's limited. So staying within that GMLOS is huge for any system. And if you want to talk the language of clinical leadership or hospital finance, this is it. Interesting, though, that a lot of sites have not paid attention to this, but they certainly are now, if they haven't been. It's hard to find anybody, I think, anymore who isn't strongly focused on this. So we'll talk more about, and I've mentioned a few ways already, but we'll talk more about how can we help to support that. And I just talked about the idea of a quote bed, right? So our sites talk about bed utilization, they talk about census. All of that requires all of the needed equipment being available. How do we best do that? Well, we just like we do everything else, we try to anticipate the needs. We have the equipment that's needed ready. We're smart about how we do preventive maintenance or alternative approaches more and more. We look to maximize equipment. We'll talk about some ways and a few ideas, but I'm sure some already come to mind for most of you. And overall, improving the effective capacity. Guy mentioned that term in the introduction. And if I might give a quick definition for effective capacity, it's basically a simple division where you have the denominator is your number of physical beds. Your numerator is how many of those beds can actually have a patient in them. Beds are out of service because the bed itself needs maintenance, because you don't have the staff to support it, or because there's not the rest of the equipment that's needed. You don't have a monitor. You've got a respiratory unit, or a COVID unit, or whatever else these days, and you don't have ventilators to support them. The room itself needs maintenance, right? Somebody had to get in the ceiling, it's not cleaned yet, and all those kind of reasons. So how many of your beds are not able to be used compared to the number of total physical beds that you theoretically could have. The overall goal here is to get your effective capacity as close as possible to 100%. That's what we're going for. That's what our systems need. And that is really, stated or not, that is absolutely a part of our mission in these days. And in many of our sites already today, it's got to be more than 100%. So what are some things that are different for HTM when you start to think and act and work this way? Well, we've all taken some different approaches to equipment dispatch and management. In some cases, there's not one, and it really is totally ad hoc. In other cases, it's unit by unit. Some of you have gone with really a centralized dispatch. In some cases, for high volume of equipment, IV pumps, for instance, either we or sterilization or a third party manage that whole supply. Well, it's not just pumps anymore. We need to look at everything and how we are best deploying our equipment and paying attention to that. It does help then with reduced ad hoc requests. It helps to put in place ways to escalate issues, whether that's support and repair that we need, or whether that's equipment that a unit needs. And as we just talked about a minute ago, overall maintenance, both preventive and working to do repairs, right? All of it, corrective maintenance, preventive maintenance, all of it can then factor into how we do this and start to do modeling of what do we have available that will go a long way towards helping to understand what we have too much of and shouldn't be paying for and can start to pare down, what we need more of, and be able to present solid plans to our leadership to support the way that we believe the organization should go for different equipment levels and different types of equipment. Some of you have used RTLS very successfully, many. It's been, well, it's a sort of a cool idea, but it really hasn't done much for us, or we really haven't used it. This is the potential real use as we look at keeping better tabs on equipment, understanding the flow of the equipment itself, helping staff to better understand and find and use equipment. So this could be a way to leverage that technology as well. And overall, for us to be a part of the planning and management for the equipment and the needs to support patients, especially in times like right now when our systems are so stressed and people are so stressed. The more problems we can help to get rid of, the better. It positions us, it keeps the stress lower on us and our teams, and overall supports our real mission of supporting patient care. So one way that many systems, and some of yours, I know, are well along in this kind of thinking as well, is to look at overall, whether your system is a single site or whether it's 20 sites, overall centralized capacity, meaning patient capacity, and resource center. And the two key takeaways from this, and that were shown on that throughput, on that flow diagram, are enabling this real-time data so that all of this can be managed. Right? Talked about RTLS, we talked about being aware of needs, talking about understanding and potentially setting up some central equipment dispatch. Do you know where all your stuff is? Simply said. Some of it's easy, right? The cath lab isn't going to get up and walk away, but ultrasound and all of the typical biomed equipment, most of it, right? Do we really know where it is? How much do you get back with from your laundry supplier? And then the real-time alignment and communication. This is us and everybody being on the same page to know what we need, when, where, why, and do we have a way to make it happen? Okay. And really, we are completely, literally talking about mission control. In non-COVID days, these are single physical locations. In these days, it's probably a mix of physical location and virtual. These are some of the kinds of dashboards. These happen to be Epic's version of them, but every major EMR has the equivalent for these. And the idea is you've got a full group of folks who do transfer and bed planning, and the list of people who provide support and resources to make a hospital operationally function. They are all together. They can communicate with each other in real time. They can, and when I say real time, I mean not, picking up a phone and somebody might or might not answer, or sending an email. I mean direct, real, either face-to-face or active chat kind of enabled kind of communication. What's going on in your ED? What patients are coming in and which ones need to be moved? How full are you right now? Who's coming in? What surgeries are coming in? Who's planned to be discharged? How are your patients moving along in their post-operative states so that you can anticipate needs? Okay. These aren't all. In most of these kind of centers, there's at least 6 and usually 8. 4 are going to be some version of what you see here. Others include the more operational areas around transport, emergency transport. This is often the place rather than individual hospitals. This is, if you have multiple hospitals, this is where a squad is going to call in. This is where life flight interface person is based. This is where facilities has somebody who can expedite rooms being tended to. This is where somebody from your environmental services, your housekeeping group, is to make sure that they are prioritizing and doing things in the right order. This is where I will suggest we might have a seat. Okay. So if we're talking about capacity and resources being managed here, capacity. So monitoring and maximizing that bed utilization. Remember, we're going for as close to 100% effective capacity. We're never going to get there because, yes, things happen in real life. But how do we minimize the issues that keep us from getting there? right? Bed planning, transfers, nudging. Usually that means nudging of providers. Hey, we really need to move this patient. Can you write the discharge order? Hey, we really need to move this patient, but they're waiting for this one imaging study. We really need to move this patient along, but they haven't had their last physical therapy session yet. All the reasons that patients don't move, and from our end, some of us support durable medical equipment, some don't, but that's another reason as well. Hey, they haven't gotten their stuff yet. And predictive modeling. How do we look at, and sometimes this is not complicated. How do we look at it? This is history. We know historically what we see at our EDs on this day. We know what surgeries are scheduled. Let's ripple that through and see if we're going to have a problem. This is what the experienced charge nurses, nurse administrators that we all know and work with, this is what they do intuitively anyway. How do we help as a system capture that? And not we as HTM, but overall as a full system. Talk about predictive modeling and things for us more in just a minute. I suggested some of that a little while ago. We'll come back to that in a moment. Now, resources. Resources falls in two areas. It means staff first. Mostly that means nurses, the single largest population in all of our systems and facilities. And mostly, especially in these days of high capacity for all of us, that means bedside nurses. They are all running ragged these days. And any and everything we can do to support those folks will go a long way. Yes, I know that many of your teams are running ragged as well. So sometimes it's just being empathetic, but certainly supporting those folks is key. It means providers. Do we have enough, whether it's hospitalists or specialists of some type? And then it also means other specialty areas. A lot of sites are finding, even before COVID, that the biggest need to help keep patients moving along after bedside nurses is respiratory therapists. So all of those kind of areas to make sure that we have those right staff, and how do we get out ahead of that and predict it? That's what our systems are looking at. Resources also means equipment. It means all of the equipment that we collectively support. It means everything that our facilities friends do. It means transport. It means having the room ready. So that means our environmental services or housekeeping or whatever your system calls them. It means those folks. This is everybody and everything connected with having the equipment there, functioning, and clean and ready to go. And then there's a lot that supports that, right? Sterile processing. They're not directly a part of this, but if they're not doing their work, obviously that impacts the whole process. And to say, and not to say that they aren't doing their work, but if nobody has let them know that there's going to be these changes, it's the same thing that we face, right? And that's one of the things we often feel like, well, people call us at the last minute or don't tell us early enough or want to do this or that. Yeah, that's true. That happens, and it shouldn't. But we're not the only ones that happens to. So a lot of this work and this planning is to avoid that. is to get people working together. So having this kind of mission control is a huge step toward toward avoiding all of those kind of problems. And one of the reasons that I especially wanted to bring this up for all of you is that the HTM team is not necessarily top of mind when these kind of systems, these kind of processes and whole new functions are put into place. So, keep eyes and ears open and suggest it, and it'll be one of those things where people say, "Oh yeah." So, so be aware, and I'll ask you to think about it, not as something else we got to do, but as a real opportunity to help avoid a lot of the things that we complain about that are all too real. So how do we make some of this stuff happen? I'll start to come back and cover some areas that we have already. So being at the table for planning, right? If we're going to be leaders around this and really start to make an even bigger contribution, we got to show up. So sometimes we're already invited. If not, we have to find ways to invite ourselves. And that's the daily, what do we got to take care of today, huddles and leadership meetings. And thankfully, most of you are in most of those already. But the bed huddles and the other things we talked about, to the bigger planning, to the work that nobody likes to do around strategic planning, around budgets, around finance, all that kind of stuff. But we've got to be there. Knowing our contribution and where are the gaps, right? Making our direct impact visible on operations. If you are looking at some of the things that we've talked about here, you'll have data beyond the measures that we traditionally use to try to secure funding. You can start to make a much stronger operational connection and get more people on your side to support you. Typically we have nursing supporting us. Typically we will have specialists supporting us because we're getting things they need. But you'll get a whole lot more folks on your side and make contributions more visible. Know the language. We talked a little bit about some of the terms and what's happening in these days. Knowing and understanding so that when somebody says something, we'll know, well, that might apply to us. How and where can we support? And I mentioned as well that there often will be dashboards or metrics that are used for all of this. Finding out what a couple of those key ones are, really knowing what's going on in your site is important. It helps your whole team to be more connected. It also helps you to know ways where you can make contribution, where you can anticipate. How do you better be ready, avoid the bottlenecks? So finding those and showing those. And I know some of you do already, right? You got to monitor up in the break room. In the past, some systems were reluctant to show that kind of data. And of course, no, it doesn't show any PHI. It just shows rolled up numbers. But a lot of sites were reluctant to share that data. That's changing. If you don't already have something like that, look into it. Help your team be connected, be more a part of the solution and what's going on. So with that, we will go ahead and start taking some questions. Oops.
Great, Doug, and thank you. That was absolutely fantastic. We're going to go ahead and switch over to video here and welcome everyone back after today's presentation. On the very bottom of the controls, you'll be able to see pretty easily a way to submit questions for Doug and myself, and I'll help moderate as we go. So as we are waiting, I'll just say I have a couple observations. One, I'm always extremely impressed working within this field to see the touch points and opportunities for clinical engineering across healthcare. As Doug said, this is not something else we have to do, but it's something else meaningful, innovative, important that we should do, that we should be getting involved with, which is exciting. The ability for clinical engineering HCM to collaborate cross-functionally is so powerful in today's world to optimize patient throughput, to help increase effective capacity, to drive the true mission of supporting patient care and outcomes. So I'm excited to see this connection, and I'm excited to see kind of where this goes in the future. So just a few quick questions while we're waiting for additional questions for Doug. One is, clinical engineering really ultimately has a bold mission. And we typically will hear about the 5 rights in medical devices, in medical clinical care, but also in medical devices, about getting the right product to the right patient at the right place, at the right care setting, clinician, to the right route at the right time, ultimately to achieve the best outcome. How do you see care pathways really being instrumental in being used to help standardize and look at medical device utilization usage within an organization? Where do you see this going?
Yeah, so first thing is to key on a word you used toward the end there, which is standardize, right? Being able to standardize the processes, being able to standardize the equipment so that we can know and better anticipate, and it's never going to be perfect, but better anticipate needs, do better planning, and start to connect the equipment needs with patient needs in a whole different way, at a whole different level, for us and for our direct customers, right? For all the clinicians that we support, so that what we do becomes just as much a part of their planning as any other aspect of patient care.
Excellent. I think this year, probably more so than any recent years, we've seen just a huge influx, obviously, of virtual care, remote monitoring, home care expansions. How should HCM clinical engineering think about clinical quality of medical grade devices within the home? And do you see care pathways also being used in an outpatient setting, outpatient environment?
Yeah, boy, that's a big one and a tough one. So a couple of starting points. Most of our systems have really ramped up in these pandemic days, have really ramped up virtual care, remote health care, however your organization is saying it. There's been a lot of promise for a long time, but now it's beginning to be realized, and has to be, both for capacity and to keep infection rates down. So there's no one answer. One is, though, to start thinking about how are we going to take care of that kind of equipment, to really start to think about extending our equipment care models outside of facilities. I will use the term depot repair, but know that I mean that very broadly. It might mean setting up a traditional physical depot. It might mean setting up mini stations. It might mean a mobile unit. It might mean a hybrid of your own services and/or services that organizations like PartSource offer. It might mean setting up an operation at scale with PartSource or another organization. It could happen in a lot of ways, but we're going to have to face it. We're going to have to deal with it. Otherwise, we're going to be left out of a growing part of healthcare. remote and virtual care is the largest, fastest growing area, and it's not going to stop when the pandemic is done. So if we're not part of that, we're going to be left taking care of a smaller and smaller portion of the total healthcare experience for patients.
That's excellent. I see a question come through. It has to do with where to start and how to start. So we've seen clinical engineering and the roles and responsibility, ultimately the job function evolve and change, including telemedicine, as you just mentioned, cybersecurity, remote monitoring, capital planning, and it keeps going on and on. Where would you start if you've just entered an organization, for example, medium-sized health system? How would you start getting involved in clinical pathway discussion? Who should you interact with? What's the best ways to at least get the dialogue started?
Yeah, so that's a good question. I guess a couple of quick thoughts. One is use our normal good contacts. So, nursing leadership tends to be groups that we have a strong relationship with for most teams. See what's going on with them. Some of the areas that we talked about here, that they're doing and they're implementing, everything from bed huddles to larger planning, be a part of that. Start to show up. Another will depend on where your team reports to, and that's all over the map, unfortunately, for all of us. But to work through your leadership, to suggest ways where you can add value, to present your value as broadly, in as broad a terms and as operational and financial a terms as possible. We've all gotten a lot better at the financial. I don't know as we've made as much progress on the operational side. So that's another way to think about it, because really this is all about operations, and we're an operations kind of group. We're operations kind of people. So there are some natural connections there. We just have to help make sure people see them.
Excellent. We'll give folks another few seconds to send any additional questions through to Doug, and we'll wrap up here shortly. I couldn't help but think, Doug, about the 2 points you made, really this idea of optimizing patient throughput and increasing effective capacity. And I'm excited to see kind of the progress you've made. We always stay in touch because it's very innovative, and I feel like there's more to come in this area. So thanks for leading the charge there at Ohio Health, and all the good work you do. Appreciate it.
Yeah.
With that, I will thank you and for you and your presentation. And the dogs apparently are out today. So we'll turn this back over to Colleen to help wrap up. And thanks, Doug, for your time.
Absolutely. Glad you all joined.
Yes, thank you, guys. There was one last question, Doug. We have a minute or so. Might get a quick answer on this one.
Sure.
A gentleman asks, what is your advice to expedite and ensure availability of resources necessary for patient care? He talks about, before that, he talks about backlogs of equipment and parts due to the pandemic. And he's looking for any advice to expedite and ensure availability.
Yeah, that certainly is a very real problem that we're all facing, and not just for our equipment, almost everything that our systems are buying. So, of course, the best answer that we all know is it's a little, on the one hand, it's a little late, but it's never too late, which is anticipate and work ahead as much as you can. Whether your partner is PartSource or others, get out as far ahead of orders as you can. Anticipate, look at trends, pull data in ways that and amounts that you never have before, because you need to start taking that bigger, longer look. And, beyond that, being as smart as we can with what we have. This is another area where often standardization helps us, but if that's where you have a problem for one type of equipment, just like your financial portfolio, diversity might help you here. But understanding what you need and getting out as far ahead of it at this point is probably the single most important thing in my view.
Great, thanks, Doug. Again, thank you, Doug, for presenting today. Thank you, Guy, for helping host, and to all of our attendees, thank you for your time, both today and any of the other sessions during our leadership series that you've attended. As a reminder, all of the attendees, you will receive a follow-up email, including a link to the recording of today's presentation within 2 to 3 business days or sooner if possible, that you're welcome to review and share with your colleagues. At this time, the webcast is ending. Thank you for attending and have a wonderful day.